Hi, Monty.
Hi, Nagai. How are you?
I'm all right. Thank you. How are you?
Good. Okay. So I'm an interventional nephrologist in Chicago and
I'm an interventional nephrologist in Dallas, and welcome to the Nephro-Logic podcast. Today, we've got lots of random thoughts for everybody. I think a lot of this is based off experiences. What do you do? What do I do? What does the data say? Or is there any data at all? So go for it. What's on your mind today?
I'm thinking about one that came up with a patient who had a newly placed fistula. And he's a relatively young guy in his 40s. And he was asking me about whether there were any things to avoid with regard to his fistula, specifically exercise. What do you tell your patients when they get a new access placed about either avoiding or not avoiding weightlifting, heavy lifting? What do you tell them?
Great question. Because this is something that I've asked a lot of people also, and surgeons and non-surgeons, and everybody gives me a different answer. I typically say 5 pounds for 2 weeks. And then after 2 weeks, depending on how everything seems to settle and mature, how the incision looks, how the skin looks, I start going from there. The mature, established fistula 3 months out, 4 months out, 6 months out, I tell these people, no restrictions. I say, you can do whatever you want to do with that arm, lift whatever you want to lift. I mean, honestly, how much are most of our patients lifting?
Well, I mean, in the event that somebody's actually a serious weightlifter, and we always want to encourage physical exercise. But I think that what's mostly important is that there is zero data. So what you're describing is you're concerned about the incisional site, I assume. Is that right?
Correct.
Yeah. So I've heard patients coming back to me saying, my doctor, my surgeon, my nephrologist told me no lifting in this arm in perpetuity more than 10 or 15 pounds. And I'm like, ask them for the data on that because there is none. So I just encourage people to lift. If there's an issue postoperatively with their incisional site, typically that message is coming from the surgeon and not so much from me. By the time they see me, if there's something wrong with the fistula or they're needing for it to be rubber stamped before they get it cannulated, I just say, go forth and take care of it on your, exercise it with impunity because nothing bad is going to happen. And in fact, there are studies, at least pre-fistula creation, that show that isometric exercises is really beneficial for fistula maturation as opposed to isotonic. So isometric, the ball squeeze, as opposed to joint movement, it shows a 30% increase in maturation. So I think the more people exercise, the better off they are.
In general, I agree. I see a lot of it, and it comes from everybody. I don't blame it on the surgeons necessarily. It comes from the dialysis centers as well.
Yeah.
They're told, oh no, your access arm, you can't lift more than 15 pounds for the rest of your life.
I think that's silly because there's no data to support that.
None.
And what happens when you see these patients long-term is you've had this happen. They come to you because the nephrologist has then, 2 years later referred them, especially the elderly ones, because they have shoulder pain and they think somehow they have to rule out there being a problem with their dialysis access. Let's say it's a patient with a brachiocephalic fistula. Their fistula is fine. When you actually press on their shoulder, they've got frozen shoulder.
Correct.
Because they've been really very restrictive with their movement because they've taken care not, harm their fistula. And then they end up with another problem, a bone and joint problem. So move, free, lift, whatever you want. There's no data to support otherwise.
That's how I feel too. Mobility exercises is huge, and I think we don't push it enough for these patients.
What's another one for you?
Let's talk about catheters for a second. What's your favorite perm cath to use? And this is not a brand discussion. This is a tip style discussion. Do you like split tip, step tip, or symmetrical tips?
I like split tip, although I don't always use split tip as the first pass. And it's generally because my hospital has erratic stock. So oftentimes I end up starting with that step tip. But if there's some mysterious reason why the patient continues to not have good flow, adequate angiography, SVC angiogram, still can't seem to sort out why the patient is not having great flow. Maybe it's getting stuck against the wall or whatever. Seems to me that the magical action is to put in a split tip. And in my view, that has been my go-to, and that's what tends to work really well. Plus, I don't think this has been studied, but my anecdotal impression is that they tend to have less issues with fibrin sheath formation just because they are split. So as the fibrin sheath is tracking down the catheter, it's less likely to bifurcate like a carina and actually impact both of the ports. So at least one of them can remain functional.
Okay, I'll show you a picture. I had one with a fibrin sheath on because I do a pullback angiogram.
Yep, I do too.
And so both independent tips had its own fibrin sheath.
I want to see that because I generally don't see that, but I want to see that. I think the odds of that happening Maybe there is much. I don't know. I just don't see it, but maybe they're out there.
Let me ask you this. One person told me, I take the split tip and I split it even more. And
I do that.
Do you? Do you pull it?
I do that. Yep. At least another 2 to 3 centimeters.
Why?
Because it's, again, with this notion, I mean, this is not scientifically based at all, but it's just the notion that when a catheter is in for a long period of time, especially for catheter consigned patients, their biggest risk is fibrin sheath formation. And the further apart those ports are, I believe, or at least theoretically, that the less likely at least one of those ports is going to be impacted by a fibrin sheath. And, for our audience who's listening to me, maybe you'll dispute this. I would welcome this to be disputed because I have no basis for saying that, but it's just an impression that I have.
Do you worry about disruption of the catheter when you split it? Tears
No.
or anything like that? Nothing.
No, because when I put them in, I put them in with the inner stylet and the supporter. So, because I do my catheters a little different than you. So both tips are getting inserted when I'm putting them in and they're going and landing in the right spot. One of them is not splaying out into some strange location. So they're being placed appropriately.
I like the symmetrical tip catheters. And 2 reasons for that. A, I think we reverse the lines a lot more than we recognize. And second, documented. So if they do it, fine, so what? If it's a symmetrical tip. B, this way both tips are in the right atrium. And that way I think it's the best chance at optimizing flow. I've had a lot of instances with either a step or a split with that arterial tip being higher up. When that catheter repositions and comes up higher, it ends up in an awkward place in the SVC. The left-sided catheters where the arterial tip is now pointing up against the wall laterally. Yep. And so I'm not a fan of split tips. I prefer the symmetrical tip only for those reasons. But again, can I prove to you that my catheters that are symmetrical tips do better than split tips? No.
Yeah, no, I'm with you.
What about French size? Does it matter to you? 14 French, 15 French, 15.5. There's a 16 French.
In general, I'm putting in 15.5s or 16s. You can get a sufficient blood pump speed out of those, 375, 400. And if a patient's on dialysis long enough, they're getting sufficient clearance. How about you?
Again, it's more on the tip design than the French. I have one patient that is larger that I do put in a 16 French just to get him higher flows. But I don't, that's not a factor for me. I tend to carry several different brands and styles of catheters. So if a patient comes back after a catheter's placed, my automatic answer is grab me a different one.
Yeah, do something.
Do something different. I think there's a lot of variability in the right atrial shape. And some catheter tip designs work better in certain right atria than others. I wish I could have a magic answer. I would say the one thing that I do that I don't know that a lot of people do, as soon as I place the catheter, I inject in the final position through the arterial port to see exactly where it is in that right atrium and get a nice picture of it.
So you know that there are anatomic, I think that that's an interesting practice. I don't tend to do that, but I always just do my angio when my initial cannulation's gone in through the dilator. They're anatomical landmarks. I think doing angiography to identify where the arterial port is useful, but you should also be able to see that on the basis of where the carina is. And I remember Gerald Beathard in one of his, many excellent lectures actually stating, and I now have this paper that I support that I show the trainees, they're actually anatomic criteria for where the right atrial SVC junction is. And it's at 2.4 vertebral bodies below the carina. So as long as you're checking that during fluoroscopy and you know that if the patient has either large breasts or a rotund abdomen, that the tip is going to migrate up when they stand, you can place it a little bit deeper in the right atrium, knowing that it's going to be in the proper position when they are primed for dialysis in a 30-degree reclining position. So that's helpful to me, and I use that typically as a guide.
You know what? Do a run for your final angio, because you will see sometimes the venous tip is sitting at the bottom of the wall that needs micro adjustments to pull it back. Try it out. See what you think.
I'll do that. Tom Vesely says, who's at WashU for a long time, interventional radiologist, really expert in dialysis access, flow is boss. And that's where it is. You have to land it in the right spot. Otherwise, your flow is going to be a big impediment. You probably do a forceful flush out of each port once you get the catheter in. Is that something that you teach your trainees when they come by, or that you teach people that if you're going and doing a workshop? I think that that's imperative to hook up a 10 cc syringe on each port, pull, aspirate, forcefully flush. And if there's any stutter or stagger, something's off. Maybe there's a kink, maybe it's on the SVC, maybe there's an issue with it.
I do it on both sides. You want to flush and you want to push and get a sense. But what's the math? I think the 10 cc syringe needs to be able to fill inside of 2 seconds.
Yes.
So if you can fill 10 cc's in 2 seconds, you can get 300 mLs a minute. It's the
Yep.
flow, right? And most of the
Yep.
time it's faster than that, but that's your quick and dirty. It is more useful to me after a catheter exchange. You do an angiogram, you do a fibrin sheath, get the new catheter tip in, and then sometimes it doesn't
Yep.
pull. Something's not
Yep.
right. Go back in there, do another angiogram, do another pill. Maybe there's a fibrin sheath remnant that needs to go, but absolutely aspiration, 2 seconds for a 10 cc syringe. You got to do it.
Yep. Forceful flushing, forceful aspiration. I'm with you.
Because otherwise, if you don't, what's going to happen? They're going to be back next week.
That's right.
Okay, here's one. I've had patients that I've exchanged out. Everything's looked great, but the catheter still doesn't work. Do you do site rotations then? Do you think left-sided catheters work better or worse? Is there any data to say left-sided catheters versus right-sided catheters do better or worse?
I don't believe there's data in terms of functionality. What I do know that there's data on is stenosis development in the central veins, which is why, in general, we preach starting on the right side because it's a straighter shot down to the right atrium as opposed to doing it on the left. But in terms of function, assuming both are actually, the tips are placed in the same exact location, there, to my knowledge, is no study that supports that right-sided catheter placements have better function than left side.
So if you've changed the catheter out 3 times over the course of 2 months, now the physician dialysis center says, put it on the left. This one's not working. Put it on the left. What do you do? What do you say?
Yeah, I don't necessarily abide by that. I think that there's usually a problem that you can find by doing really careful angiography. And I will be more likely to keep it on the same side, particularly because the whole reason that it's on that side is because you're looking for some opportunity for vascular access on the other side. And if that patient has been forgotten about for months on end, now you're going to have stenosis on both sides. So I really troubleshoot a lot. If you're having issues on the same side, there's usually a reason. And it's what you said. There's either a remnant fibrin sheath, or you just need to place the axis a little bit deeper because for some reason it's migrating up. And then I'll use a different type of a tip. So that's a time with which I'll migrate from a step tip to a split tip and really widen my split. And honestly, my experience has been that's what works. It's not switching sides.
The one thing I will do in a scenario like that also is I'll pull the wire back and rewire.
Yeah.
People are taught, park the wire in the IVC, never lose that wire. And that only works if you assume everything is patent. But if there's a remnant fibrin sheath, you're parked in it.
You're right. You're rewiring a piece of fibrin sheath that maybe you can't see, but is going to just continue to cause you a problem. Yeah. I agree.
What about parking a catheter in the IVC when you are not able to do an SVC right atrial catheter? Do you do that a lot?
I never do that, but I usually get 1 or 2 of those exchanges a year from outside hospitals. And I'm scratching my head going, why is this catheter all the way down in the IVC? I don't abide by that practice because I think that then you're actually screwing up several locations potentially, and you're contributing to the potential for a very long fibrin sheath. And we know over time when these patients start running out of dialysis access opportunities, I just don't want to screw up their IVC because sometimes that can be a location for a beneficial thigh graft, a thigh fistula. So no, I will work hard to keep it above the diaphragm. I will not put it in the IVC, but I get occasional exchanges where I'm just like, okay, we got to find another way. How about you? Do you do that?
I don't routinely do it. I have done it as a last resort. And on those patients, sometimes it works, sometimes it doesn't. Okay, fibrin sheath, is that the source of stenosis in the SVC, IVC? Is that the cause? Is that why you don't want to park it in the IVC? Because a fibrin sheath is the source?
I don't want to park it in the IVC because the fibrin sheath can be the source. And in my experience, which isn't that great with long catheters that are originating in the IJ and getting past that far, if you have, it's what you said about rewiring. The issue is that when you get dysfunction, unless you're actually really taking care to wire into an area that is not where the existing fibrin sheath was, you are going to continue to get dysfunction after dysfunction of newly placed catheters. So I would rather have my fibrin sheath be as short as possible in an area that I can control easily, as opposed to continuing to extend it down into the inferior vena cava, because then kind of all bets are off. It can go anywhere. And then when you really need to have a femoral access, you may have botched that opportunity, or at least it makes it more difficult to sort out what the issues are with flow. So I just like to stay in my 2 separate compartments. I keep it separate, like above diaphragm, below the diaphragm. Yeah.
You're below the diaphragm catheters, though. Do you keep them IVC, iliac, or do you take 50 centimeter all the way into right atrium?
No. For femoral catheters?
Yeah.
No, I go for L4, L5. That's where my tip lands. Why would you do that? What's the benefit?
Because that's where you're going to get the best flows in the right atrium.
Yeah, no, I haven't had problems with getting a 400 pump speed.
Why is it that the right atrium is the target for an SVC, but an IVC is an adequate target if your IVC and your SVC are similar diameters? Why isn't the right atrium the target irrespective of where you get there from?
Yeah, that's a good question. I don't necessarily have a good answer for that. It's probably just one of those fallback answers, like that's just what I've been taught. This would be a call a friend. Gerald Bethard would probably have a good explanation. But that's a really good question. And one of our listeners is going to comment on it when they see that.
So there's two schools of thought. One is exactly start low in the IVC, and then for the first exchange, go up a little bit higher. So start off with a 35, and then I go to a 40, and then I go to a 42. Or the second opinion is, if the right atrium is the target, it doesn't matter which side I come from or which direction, top or bottom I come from, put in the right atrium.
Is that what you do?
That's what I do. I just go for a right atrial catheter.
This may end up being one of those controversial topics that could warrant a lot of conversation, because I think everybody has a different approach on this. And you're right. I don't have a good explanation as to why I do that. I landed in a place that's not going to be problematic, that gets beneficial flow. I haven't had to park it in the right atrium to get good flow to date, and I've done this for over 20 years. But for those people that routinely practice like that, you make a good point.
Because everything you said applies the same above the diaphragm or below the diaphragm.
It does.
But why is the rule above the diaphragm then keep it out of the SVC and go into the right atrium?
I think one reason now, as I'm considering this and we're talking about this live, is that I want to try and reduce, it's not just fibrin sheath formation, it's stenosis. And so I want to reduce the opportunities for a long segment of stenosis to develop, because we've all seen that too. So the tip, knocking along the walls, all of that. And so knowing what happens in the left side, left IJ catheters, the entire pathway through the brachiocephalic, proximal superior vena cava, etc., can develop stenosis simply because of the path of that catheter. My view is to try and keep that as limited as possible while still providing sufficient flow for the catheter, which is, I think, the reason why I've just done L4, L5, because I don't want to have any issues around IVC drainage, IVC opportunity, and stenosis development. So that's the answer I'm sticking to.
Okay, but hold on. Is it the course of the catheter, or is it where the tip is? Because your tip is banging up against the wall.
Both.
Your tip will get your thrombus, catheter-associated thrombus is tip dependent. So
It's both, because what we see, you see this. I mean, when you have patients who have a catheter that goes in through the iliacs, iliac stenosis develops. That's not where the tip of the catheter, but that's where the course of the catheter goes. And so it's actually both. I mean, you can get tip thrombus, but I'm more worried about the course of the catheter and the fact that the catheter is just banging against the walls as it's traveling up to its endpoint. And so I'm concerned about the entire pathway. So as you're trailing this thing up all the way to the right atrium, in my potential view, you're promoting the potential for stenosis to develop along the entirety of that course, whereas I'm limiting mine to L4, L5. But I'm going to have to look this up. I don't think there's been any study that has shown what opportune positioning for a femoral catheter and the development of stenosis or dysfunction over time, long-term consequences, depending on tip placement.
Okay. We hammered catheters more than I thought we would. What else you got?
I know. Okay. So the long-term patients, I saw a patient at one of the meetings that I was at probably in the last 3 or 4 years who had a mega fistula, radiocephalic, and he was a guy who did home hemodialysis, super educated, camped, took his machine with him everywhere, very, very independent. And he had a practice of wrapping his fistula with Coban because it was quite dilated. And at the end of dialysis, when I asked him about why he had this practice, he said, because when the fistula is dependent, arms are down, and he's got all this flow augmentation that's going through the fistula, that it's more likely to actually dilate, akin to a varicose vein in a sense. So the fact that it's dependent means that it would dilate over time when you leave it to gravity. And so he didn't want to have this even bigger fistula on his arm. And so he would carefully wrap it with Covan, not to compress it fully, almost like a compression stocking. And he believed that prevented it from becoming really disfigured and kept it kind of in check. Have you seen that? Have you heard of that before?
I have not.
Yeah, it sort of makes sense.
That's really clever. I don't agree that it's a varicose kind of style of dilation that's valve related because you've got pressure. However, I think the benefit here may be more of flow modulation, that with a partial compression, you're getting flow reduction when you're not using it for dialysis. This concept of I need 600 during the treatment, but why can't I live off 200 for the other hours of the week? And because there is no continuous high flow is when you would get reduced dilation. I think that's a really clever idea.
Yeah, it was really neat. And I would caution anybody who's listening to this to overwrap their fistulas with Coban. But this is a patient, N of 1, who had this practice for, I think his fistula was 15 or 16 years old. And he did this in a fastidious way, and it really kind of kept it in check. And it also made him more comfortable because it was protected. So he wasn't as worried about nicks or potential cuts or harm coming to him from a relatively high flow fistula. But I thought that was really a neat approach.
And I have had a lot of patients that are very physically active have told me that they do wear a sleeve just from a protection standpoint, and they're more comfortable with that. And I think that's completely reasonable. The flow modulation idea is great. Putting a compression dressing to reduce flow when not in use, I like that.
Yeah, it's pretty neat. Yeah. I don't know if we've covered this before, but will you put an access in a patient who has central venous occlusion, but who is well collateralized? Will you put it on the ipsilateral side of that central occlusion?
Yes, I will. But it's a very selective access or a selective surgeon that will do it for me. As long as the flow's under control and I know I have an access that I can keep it around 1,000, generally speaking, they should do okay. I've had percutaneous fistula with central occlusions that did not have symptomatic arm swelling. What's the concern? Symptomatic arm swelling.
That's it.
That's it. They'll dialyze appropriately. They'll dialyze just fine. They won't even have prolonged bleeding if they're collateralized well. The only concern is symptomatic arm swelling. And if you have a flow that can be controlled enough, then yes, absolutely. But that requires, I think, probably a brachiocephalic, radiocephalic percutaneous fistula. Brachiobasilic fistula is the one that I worry about that would run away on me to get high. It seems like my brachiobasilics that I get in my community are higher flows than my brachiocephalics. Do I have data to support that? No. I think this is really a surgeon-driven answer in that who do I know that can give me the best moderate flow fistula that's not going to turn into a high flow fistula?
Yeah, I'm with you on that. Although my brachiobasilic fistulas tend to have lower flow than the brachiocephalics, just because I think they got proximal swing segment stenosis, and that kind of keeps them in check. But yes, I frequently will tell the surgeon, please keep the arteriotomy around 4 millimeters, and so that the patient doesn't have a significant amount of volume flow going through it. But I think that they work really well when the patient's well collateralized, for sure.
Really? Your brachiobasilics are better controlled with your flows?
Yeah, I just do. I mean, I think the cephalic vein can get really, really dilated. And because it has the terminal cephalic, the likelihood of getting significant stenosis, unless you've really taken care to keep the arteriotomy relatively small, they can run into problems with both venous hypertension, but also high venous pressures, because that's the limiting factor is at the terminal cephalic.
Along the same lines, if they have an pacemaker defibrillator, is that an automatic no for that arm?
I treat a lot of patients who have venous hypertension, who have CIEDs on the same side as their dialysis access. I would not choose to place an access knowingly or ask for an access to be placed knowingly on the same side as a CIED. I just wouldn't. I think the patient is at risk for multiple interventions throughout the year because of that, because we see that all the time. And really hesitant to stent there makes you have to really take care with ballooning with large balloons in the subclavian vein or the brachiocephalic vein because you don't want to rupture the wires. I will choose any location other than that. That's a last-ditch effort for me. I just don't.
Even if the venogram looks good and it's wide open, you would prefer the other arm?
Well, yeah, because once you put a high flow access in, that venogram is going to change. What is open today with 50 milliliters per minute going through a cephalic vein is going to be very different than with 1,000 milliliters per minute going through a cephalic vein. And so, I mean, if you want that thing to last and have enduring patency, I don't like to place those on the same side as a CIED. No. I will put in a forearm loop graft on the contralateral side before I would advocate for, honestly, because I just know what it buys. I mean, I have patients that have to come in every 3 months because they need an angioplasty because they have a high flow access with CIED wires. I send it back to the surgeon to try and reduce volume flow to see if that helps. They have limited options on their other arm. I just think that this is going to likely happen. Why wouldn't you take action to avoid it?
Interesting. I don't do that. I'll image it. We talk about it. If the patients say, okay, fine, let's avoid it. Sometimes the patients have said, my cardiologist said, can we avoid it? Can we do it on the other side? I said, absolutely. I don't have a reason one way or the other to choose, but I don't look at it as a hard no. What about a perm cath on the CIED side? Will you do that? Or was that a hard no?
No, I'll do that. If it's looking like they have no other options, yeah, I'll do that. Unless the patient's going to be catheter consigned forever, I'll put that in with the knowledge that I'm going to be taking it out in a couple of months. I don't have an issue with that.
How do you tunnel it so that you...
Very carefully.
People have concerns about putting a catheter next to a box. How do you handle it?
I don't do a lot of these, but you really have to steer clear of where the pocket is for sure. And sometimes they get a limited tunnel that's just infraclavicular as opposed to down a little bit more comfortably on their chest wall. So you really stay away from that box. How about you?
Yeah, same. I just go a little more lateral. I have done one that was very medial and it was a very acute angle. Not a big fan of doing that because then you get a tight angle there in addition to all the other turns, but I have done that. Okay, that was an interesting thought on the box. You mentioned it, stenting across a central occlusion with the wires in place. Hard no?
With wires?
Is that a hard no for you?
I don't do that. Covered stent, I don't do that. I know that Ted Saad, who will comment on this, has published a bit on this, and he will take it under consideration and do it in certain instances. I think he's got a different opinion than I have, but I don't like to do that. I think that will be the time at which the patient will have something crazy, or if it's at the first root clavicle junction that the stent graft's going to get kinked and then kink the wire and take it with it. I think that's a big headache.
I will do it depending on the comorbidities of the patient and the age and all of that. Young patient who's in the 40s, 50s, probably not.
Yeah.
Given those concerns, my 80-year-olds that I'm pretty sure that it's this access to last them 1 or 2 more years, I don't hesitate to do it. Very much with discussions with the patient and sometimes with their EP physician.
I think that's an important point because you don't want to do something that boxes these leads without consulting the person who put the leads in. I think that is very, very important to communicate and have a conversation about that. There are no hard no's here because they really need to be considered on an individual basis with patient longevity in mind and transplant opportunity and so on.
And these are things that everybody was trained differently on how to do it. Everyone was given different backgrounds on how to do it. Every community handles differently. This is what part of meeting everybody is to say, hey, how do you do this in your region? Mani, this was a great discussion. Lots of little thoughts on how we do things. And hopefully this generates a lot of discussions with audience members as well. We'd like to know how you handle some of these scenarios, how you do it differently. I love learning from other people on how they do this, not only in the US, but also outside.
I totally agree. I'm hopeful that our listeners will enter the chat and start to comment. We'd love to hear from you, particularly about other topics that you want us to cover as well. So thanks, Nagai. We'll see you next time.
Until next time. Bye.